that the aorta coming out of the heart. Regular scans are also done of the aorta as it continues on down the body. The aorta comes around and it passes down through the chest. So that this is also prone to getting aneurysm, so this is monitored on a regular basis. And then also important is controlling blood pressure and monitoring the response to medication to control the blood pressure. In terms of surgery then, when the aortic root reaches a certain size, surgery is sometimes required, and that can involve replacement of the aortic root. You can probably reference that photo to the one I already showed you. You can see we have an artificial graft here, replacing the normal aneurysmal aorta. Similarly, if an aneurysm involves the aorta further down, and you can see here in this photo, the aorta is swollen at this point, a stent has been placed inside the aorta there as the treatment for it. So, in terms of future treatments, Darren has already talked about that, so I'll stop there. Thank you.
If anyone wants to ask Andy or the doctor any questions, feel free.
There's not a predilection towards one sex or the other. No, you can see it in both people.
Sorry, can it be detected in newborn babies immediately, or are they a certain age before
there's
tests done?
I'll tell you, mostly identified in patients who are into their teens or into their 20s. On the other hand, we're a little bit more vigilant now and perhaps a little bit more careful about evaluating newborn babies and infants. Echocardiography is increasingly available even before babies are born. And so we're tending to identify babies with Marfan syndrome from a very early age now. So what that means is it means a few things really. One, we can start therapies, medications much earlier in life, and hopefully prevent aneurysms developing. But it also means that we have begun to operate on young children increasingly. And in fact, there's a baby who was just born several months ago who has a very severe Marfans, and it may well be that we'll have to operate on that baby before she reaches her first year. And so where in the past it wasn't really identified in children and infants, and so it has reached a very severe state for some of these until they're identified. So now we have an increased opportunity to treat babies and children with Marfans syndrome.
What kind of age are the kids, the young children diagnosed? If they do have cardiac problems, what kind of age are they starting medications, or are you waiting until, are they going to start with the trial?
We'll start medications right away if they need it. Mostly, it has to be said now, most of the time, if we take, say, a family whose Marfan has been identified, and we examine the children in that family, most of the time we'll see nothing. And it develops much later in life if it is going to develop in some of those children. However, occasionally we're surprised and it does occur in younger children, and we'll start therapy right away if they have anything of an aneurysm, anything that suggests that the aorta is bigger than it should be. I have to say the majority of time there's nothing to treat initially. I'll just keep following those patients, and that's where the biomarker. The research will be so important because if you think about it, say you were diagnosed with Marfan syndrome very early in life. The best study we have at the moment is a CT scan, but that's a lot of radiation. And it would be it could be potentially dangerous for a child over, say, 30, 40, 50, 60 years with regular CT scans. So we do change this slightly. We try to do MRI scans if we can, but the CT has certain advantages. So with a biomarker, we could avoid a lot of the scans we think. So you can see how important that really is.
And somebody that has actually had all that surgery, has had the aneurysm in the base of the aorta, where would he stand? And the medication, did you say, suit, like the one to make him really sleepy? The beta blocker.
Beta blocker.
Right?
Yeah.
But now he's had all the surgery. Would all, like we say 8 years ago with the second one, would he need to have surgery again or just continuous monitoring?
No, monitoring is the key. The most immediate life-threatening, if you want, problem would be close to the heart.
Yeah.
Once we've dealt with that, we still will keep patients on beta blockers, losartan, pravastatin, hopefully in the
Doesn't take
future.
any medication.
But it depends. The reason it's important is if your blood pressure is high, we tend to need to treat that. And we're not entirely clear as to whether or not the medication is useful to prevent aneurysms or splits in the wall. That's what we worry about for the rest of the aorta. And we don't have that information. But we hopefully will gather that now that it's increasingly recognised. And we have registries, which is patients who are very carefully monitored, not just in Ireland, but particularly in the States where there are large numbers. And those registries are beginning to learn which patients, after their surgery, absolutely have to be on medication to prevent problems in the future. But you can see every medication has a price to pay.
Yeah.
That's the problem. And the beta blocker, funny enough, a beta blocker is not a bad medication in terms of its side effects from the point of view of your kidneys or your organs, but it does make patients tired. And young people just don't like taking it if they can avoid it. On the other hand, we can tell them until the cows come home that they're better off on it. That's, and you tell that to a 19-year-old, 20-year-old. And so it's very important for us to be able to identify which patients should and shouldn't be on it. Right now, the safest thing is to put as many patients who are willing to take it as we can, because we catch everybody that way. But it's not as, we want to be more focused in the future. Okay.
To what extent is exercise effective?
Say again?
And to what extent is exercise effective?
Well, what we do is, say we have somebody with an aneurysm or something that we are worried about. What do we do with exercise? Well, we do know that we saw a famous basketball player there, shown by John. One of the problems, of course, is for Marfan patients is they tend to be a very perfect physique for basketball. And so that's a very strenuous exercise. They're tall, they're slim, and they're very agile. And so as a result of that experience, particularly in North America and in the US, we know that certain patients do end up in trouble when they are involved in the extremes of sport. But it's straightforward exertion, if you want, is pretty safe. And as far as I'm concerned, patients have to be able to lead a pretty normal life. And if you don't have a good quality of life, what's the point in living? And so we have taken the view that if patients are quite anxious to get involved in extreme sports, we would have them pull back from that a little bit. You don't have to be highly competitive. And for some patients who are relatively competitive, we put them on beta blocker and other medications that we think will control things even when they're playing their sport. And heavy contact sports we try again to avoid for patients who have diagnosed problems. If they have established aneurysms, we really say no, you can't get involved in contact or heavy sport. So it's tough. It's the same thing. Patients tend to be in the prime of their health, as it were. They're young when this is diagnosed for them. But on the other hand, the benefits of having the diagnosis is that you just live a lot longer.
And what percentage of people suffer from Marfan, and what are the chances of it being picked up in the course of an ordinary medical test?
Very good question. We've all, and a lot of people ask, how many people in Ireland have Marfan syndrome right now? It's very difficult to say. And the reason is we don't know everybody who has it. In fact, I would suggest that more people have Marfan syndrome in Ireland and don't know it, compared to those who do know it. I would say, based on